The topic I've chosen is the placebo effect, and it's something which I've been interested in for a number of years now, and I hope that what I'm going to go through sparks off some kind of interest in you, or that you maybe learn something new about a topic you might not have known much about already. So this is just a brief contents of what we're going to go through. I'll start by explaining what a placebo is. I'll then go into how, where and why they're used. I'll explain briefly or an overview of the ideas and mechanisms and on how they work, because we do see genuine changes in some conditions. That brings us on to what conditions they can be effective for, can you increase the effectiveness, and then other topics such as the negatives or nocebo effects, my thoughts on placebo-like effects, which might upset a few people, and then everyone's favourite thing, which is the ethics involved, and some of the problems that we might have. So first of all, what is a placebo? A placebo is an inert agent, which means it has no pharmaceutical properties in it at all. The traditional view of them is that they're a sugar pill, but they can come in pills, tablets, capsules, injections, and more recently as well there's this area of placebo surgery. So it's basically something that's given to someone with them believing that it is an effective treatment or medicine, when really it's just an empty tablet or saline solution. The placebo effect then is the outcome or response that comes from taking that tablet or having this treatment, and it usually resembles the response that a person's told that they're going to get, or what they're expecting to get. For example, if you're in pain and you're given a painkiller, which is actually a placebo, the placebo effect would be analgesia. If someone's given a placebo to help Parkinson's disease, then there's often increases in serotonin in the person, and that's likely to result in improvements in motor control, or they'll have less rigidity. So where did the placebo come from? Well, placebo is Latin for I shall please, and they basically throughout history there's been hundreds of thousands of crazy, weird remedies believed to help and cure certain illnesses. Doctors and physicians have made miracle cures from animals' eyes, pig's blood, elephant sweat, cow urine, and it's well known in countries in the Far East to create these potions and lotions. People also have physical things done to them, so people have been cut, they've had illnesses and infections bled out or drained out of them. People who've been burned, frozen, and had random organs removed with the belief that this will make them better. Now the interesting thing is that this potion of frog's legs, pig's blood, crocodile's tears, has in a very small number of cases resulted in some people getting better. And what this does is that because people have got better, it reinforces the belief that these crazy potions are an effective remedy. But if we take a step back and say, okay, we gave this to 100 people, and actually only 2 of them got better, 54 died, 12 grown an extra leg, and no one will see or heard from the rest, we can clearly see that it is an ineffective treatment. But for those 2, it's very real. They've already evidence they need to believe that this magical drink that they've taken has cured them. But as well for the person administering it as well, all the 98 people have forgotten about, because he's created something, he's administered it, 2 people have got better, and he used the results from those 2 people to confirm everything he believes about it, which is a classic form of confirmation bias. Now as time's gone by, we have a better understanding of anatomy and physiology and actually how to conduct research. Studies and experiments started to be used to see if treatments are actually effective as people believe them to be. So what happens is the thing in question is compared against a sham treatment, or treatment which is known to have no effect on the condition that's being treated. And this isn't just for pharmaceutical treatments either. It can be for any kind of healing, which so-called healers and so on were very big up to the mid-1900s, when science really started to take off and disprove them. But that kind of thing is very big over in the West with face healers and miracle cures, probably because it's a multi-million-dollar business which runs on people's curiosity and hope. That's a whole different presentation. But therapies and treatments such as mesmerism, Perkinism, homeopathy, which were very big around 1700, started to be tested against these sham treatments. So mesmerism, or what was known as animal magnetism back in the day, it was around 1780s that Mesmer appeared in France. I think it was an Australian physician who claimed that we have this magnetic fluid in our bodies, and by utilising that with his hands, he can cure illnesses and diseases and In the 1800s, it spread across Britain, Germany, Russia. Nothing amazing had been shown, there were no miracles, but the interest and curiosity in it just made it grow. So what they would do is the magnetizer would sit opposite the person, place his palms under the person's palms, engage in quite stern eye contact. He did a few other things, and the person would fall into this magnetic sleep. And what he would do is he would make passes over the person, across the face, body, arms, almost as if he's rushing thin air, supposedly dragging this magnetic fluid away from the person. When this person was in this magnetic sleep, he could apparently do things to them, like cause pain, or rub them with itching powder, or make them smell something which would normally cause a reaction. But none of these things ever did. Now this magnetic sleep is very similar to what we know nowadays as hypnosis, which of course isn't due to anything to do with magnetic fluid, it's to do with the mind. So this mesmerism was compared against a sham treatment in which the person didn't know whether or not they had been mesmerised. Not necessarily for those being put into a sleep state, but for those whose eyes were open and watching him perform this theatrical swooping motion, they were blindfolded. And in one condition, the patient could see where he was directing this magnetic energy. And of course, they experienced heat in that area and sensations on that area that was being focused on. Now, the interesting thing is that when people were blindfolded, parts of the body which were named didn't match the parts of the body that were being focused on, so obviously nothing's really going on there, and any improvements that were found were just put down to remission, imagination, and also self-delusion. Now, Perkinism was a similar thing. People were treated using two metal rods, and they claimed that by waving these metal rods over people, they were able to reduce certain inflammations due to electrical fluid that was supposedly out. So they were placing metal rods with wooden rods, finding out there was no difference, and whatever change may have occurred wasn't due to any active rod or fluid. Now today's treatments are based more around pharmaceutical treatments and tablets, or things that you take to get better, as opposed to healing rituals. So another thing that's been disproven but more relevant today is homeopathy. And these homeopathic treatments were and still are compared against placebos, and they're found to have no greater effect. Yet homeopathic treatments are still sold in shops. You only have to go to your local chemist or pharmacy and you find a box of tablets which will claim to help you sleep. And if you look at the back of what's actually in it, it will more than likely be a homeopathic remedy. Or in other words, a solution which is diluted to such an extent that it has nothing of the original substance left in it. So why do these things sell? Well, first, it might just be because people don't realise or don't understand homeopathy. Alternatively, it might be that people buy them because they find that they do work. And they might find out they work because, one, like I said before, confirmation bias, they've taken a tablet, they've happened to fall asleep that night or slept well that night, and falsely attributed that to being the cause of the tablet. Or they're finding that these tablets are actually working, but it'll be because of a placebo effect, which is why they're found to be no different to placebos. Because in both conditions, they're both, quite frankly, receiving nothing, being told that it's something, and therefore getting a very similar response. So when people in research labs create these new medicines, they have to be tested against placebos. And for a new treatment to be brought out onto the market, it has to be more effective than a placebo in a number of research trials. Accurate in whatever condition it is that the medicine's been designed to cure. Now that would be good well from a pharmacologist's point of view. The trouble is that placebos for some conditions are still effective. And I'll put a bullet point up there saying placebos are a pain for researchers. And this is why. Let's say we're testing a new pill to cure a headache. We have 100 people, 50 go into the treatment group and 50 go into a placebo group. Okay? Of the first 50, 45 people's headaches are cured, and of the second 50, 40 people's headaches are cured. Okay? So in the treatment group, 45 out of 50, which suggests that the treatment is 90% effective. But in the placebo group, there's 80% improvement, which is the 40 out of 50. So really, only 10% of the actual treatment group's improvement is due to the actual medicine itself. A very big difference to that original 90% which we originally see, because 80% of that 90% is a placebo component. So that tablet is considered not to be effective and is then scrapped. Okay? Now to test new medicines, that's fine. Roughly 10% can be attributed to the active ingredient. But if we're measuring the size of the placebo effect, which is what I'm interested in, saying that 80% of the improvement is actually a placebo effect is wrong, which sounds confusing, but it is true considering what I've just said. Here's the problem. There's thousands of studies where one group is a treatment group and receives an active medication that's being tested. The other group is a control group and receives a placebo. Now the problem is, you cannot use a placebo group when it's a control group to determine the size of the placebo effect. Okay? Likewise, it can't be used on its own as an experimental group. A simpler way to put it, imagine that I'm testing a placebo on its effectiveness to reduce headaches. Again. So I have a group, take their baseline pain measurements and then give them a placebo. But I tell them it's paracetamol or codeine. And then I take their pain measurements an hour later, and we find out there's a 60% improvement. But out of that 60%, how many enrolled in that study at the peak of their headache and were just going to get better anyway? Probably quite a few. So the placebo group's improvement is part placebo effect mixed with spontaneous remission, regression to the mean. Okay? Which is fine if you just test a new medication. It works as a control group, then fine. But to really find out the size of the placebo effect, we need a control group for that group. Okay? Which is usually a no treatment group of people who just sit there happily and wait. So let's say 20% of these people get better, just through natural causes. All of a sudden the numbers are different. The original 80% placebo effect is now 20% natural causes and 60% placebo. The treatment group is then 20% natural causes, 60% placebo, and then that 10% due to the actual medicine still there. So just using a placebo group as a control will more often than not result in someone overemphasizing the actual size of it. So it's maybe not quite as powerful as some studies claim in a report, this is the size of the placebo effect, just because that's the size of a change in that group. It can actually be accounted by other things. But it is still there and it does still exist. And if you can account for those other variables, there's a problem with the terminology that's used, it's quite inconsistent. And, the placebo effect tends to account for the whole group change from measurement A to measurement B. But if you can control for those other factors, the term placebo response tends to purely focus on the psychophysiological response that's caused by the inert agent. So we have these placebos and we have these placebo effects. So now you might be thinking, okay, so it's telling us that you're giving them a good medication, but they're still experiencing changes as if it was a real medicine. Yes. The placebo effect is a psychobiological or psychophysiological phenomenon. You see both terms being used. They're not all that different. Biological and physiological are related to the body, and then psycho is obviously the mind. So it's how the mind influences the body's responses and function. And there's two lines of thought how these work, or two mechanisms behind how these work, should I say. And these responses can be, they're not always, but they can be actual physiological changes that occur in the body and brain, not just what most people think, myself included. Before I started reading the research around them, I was quite naive and thought, okay, it's a study on depression. They're given a placebo antidepressant, and after they just report that they're feeling a little bit happier to keep the experimenter happy. The same with pain. They're given a painkiller, and on a 10-point scale, they just rate their pain 2 or 3 numbers less than their initial rating. But if you just slightly change in your judgment on self-report measures, it doesn't explain how people can have invasive surgery with placebos or hypnosis, or have complete analgesia in certain parts of the body that the pill is said to affect. Okay, you know, there has to be something more going on there. And using technology such as CAT scans, PET scans, MRI scans, it's clear that as parts of the brain that are activated, chemicals are triggered and released, and the person experiences a true change in emotion and sensation at a physiological level, rather than just a subjective perceptual change. So the ways in which they work, the first is through expectations, and the second is through conditioning. Okay? So if we look at expectations first, These can be aided by lots of different things. First of all, obviously the verbal suggestion of, I'll use analgesia as an example because pain is one of the most widely researched areas. Someone will be given a painkiller and told, this is going to reduce the level of pain that you're feeling. So obviously that creates the expectation. And there's lots and lots of other factors which create, layer and reinforce these expectations. How do expectations improve someone's condition? Well, at a basic level, it may just simply put someone at ease and reduce their level of anxiety, which is also associated with a reduced level of pain, so it might work that way. Alternatively, brain scans have shown that expectations activate certain areas of the brain, depending on the condition that's being treated. Pain relief for placebos is associated with an increase in activity in the rostral anterior cingulate cortex, I think I got that right, which is an area of the brain also affected by opioid medication. And heroin users in the room will obviously know the link between opioids and pain. A similar thing in Parkinson's disease, those who are expected official treatments, so are releasing dopamine in striatum, which is a part of the brain that's sometimes affected by Parkinson's. And the amount of dopamine released tends to associate with decisive improvement in the person. Now, I don't know the whole neuroscience behind it. It starts to get a little bit too complicated for me. But we can clearly see that there's more going on than just imagination or subjective changes. Effects of expectations can occur through imagination or beliefs about something. The key part of expectation-induced placebos is that they're shaped by what the person believes that they will experience. And most of the time what the person believes they're going to experience is close to the actual intended drug effects. But if the expected effects are different from the actual drug effects, then it's not uncommon for the expected effects to have a stronger impact on the person than what the actual drug effects have. For example, people who have been given placebo alcohol tend to report an increase in sexual arousal. First of all, it's clearly a placebo effect that shapes their expectations because they're not receiving real alcohol. And the other problem I have with it is that alcohol is a depressant, and depressants don't increase sexual arousal. They actually decrease sexual arousal. So looking at it physiologically, no, I just don't buy it. Likewise, if you give someone placebo alcohol or give them an alcoholic drink first just to get them going, then replace it with placebo alcohol, things that are expected to be affected by alcohol, such as coordination or walking in a straight line, are affected. And the more you drink, the worse they get, even though you're not actually drinking. So what someone believes about something is more important than what it actually does. Likewise, one of the biggest placebos of them all is caffeine. From coffee, now I'm not saying caffeine doesn't work, it does. It's an adenosine antagonist. An adenosine enhances pain, reduces sleep, reduces arousal, which is why caffeine shows improvements in focus, insomnia, reduced pain, delay fatigue. But obviously people have coffee before workouts or before they start driving. They have a swig and instantly they feel better or more awake and more energized and start acting more energized. What I don't want to tell them is that it actually takes around half an hour to absorb enough caffeine to have any effect on you, and around 40 minutes to reach peak concentration levels. But because we have these preconceptions about alcohol and caffeine, it results in behaviours which follow our preconceptions, beliefs and expectations. And there's plenty of research to show that if you're in a study and given caffeine and told it's a placebo, often people don't actually experience the benefits of caffeine because you're not expecting to receive the benefits. The other way around works as well. If you're given a placebo and told it's caffeine, then it's common to find improvements in areas that you expect caffeine to improve. So alertness, focus, reaction times. Strong evidence to test expectations actually comes from open and hidden administrations. So people who are on a drip in hospital, open would be a doctor comes in, injects a solution into one of the tubes. The hidden would be that it's already in the drip or it's controlled by a machine. And then these are both manipulated to be controllable. So the doctor will inject both a real and a saline solution. And then if they believe it's in the bag, it either will be or it won't be. Okay? Obviously the genuine treatments, open injections, are more effective than hidden. But then what's interesting is that some studies have shown an open placebo is more effective than a hidden medication, which cliche just shows, the power of expectations. So that's expectations. The second way in which they work is through conditioning, which is the whole Ivan Pavlov salivating dog situation. And it's based around associations made at a subconscious level. So what happens is, over a period of time, if a stimulus is present with a particular behaviour or response on multiple occasions, the stimulus itself can become a trigger to create the same response. Some examples you might have come across: you may go to a funeral, 2 weeks later you hear a song that's played at that funeral, and all of a sudden those negative emotions you've experienced at that time come rushing back. Likewise, there may be someone you've had an argument with and you really dislike them. A couple of days later you see them and their face acts as a trigger and brings back all these negative emotions that you have towards that person. And these self-phobias work. Someone has a bad experience of something before, maybe was drowning when they're young, and then whenever they step back into a swimming pool or see water, they panic because the water acts as a trigger for these negative emotions. But this can be for positive things as well. How many times have you seen someone's attitude change or face light up when their best friend sits down? They haven't done anything yet or said anything, but that person has a lot of previous positive associations with being with that person, and all of a sudden being joined by him or her is enough to trigger this positive state, which is normally experienced when this person's around in their company. Now, in relation to medicine or tablets, there's lots of things that can be conditioned. Normally we condition, with conditioning, people will receive a real course of treatment. The treatment will then be interrupted with a placebo. But because the body has been having a blue tablet and experiencing genuine pain relief for the last 3 days, when they receive a blue tablet, which is actually a placebo on the 4th and 5th day, the body continues to experience benefit because the association is there. Someone who's taken an antidepressant experiences an increase in serotonin due to the tablets. When they're then taking a placebo, the body's still expecting an increase in serotonin and causes that exactly to happen. And there's also been studies, or a study which conditioned the smell of vanilla with someone's bronchodilator. So after time, just smelling vanilla produced very similar effects to what using a bronchodilator would have. And this is objective data as well, so pulmonary function, not just self-reports. But obviously, it doesn't work for everybody. And these two tend to fall into conscious and unconscious categories. Expectations tend to be created consciously, whereas conditioning tends to work unconsciously. And they both work for different things. Some conditions work for expectations, which is the case for pain and Parkinson's, whereas conditions that are more hormone-based are more conditioning effects. And there's some things which expectations work for, conditioning doesn't, and then there's some things which conditioning doesn't for expectation. And you can work out by what mechanisms they work by giving one group a placebo, an injection to create expectations, and another group real treatment to create genuine drug responses. Then after a period of time, swap that drug for a placebo. If they continue to experience drug effects from a placebo, then the expectation group has received any benefit, then it can be put down to conditioning effects. If both groups improve the same, then you'd expect the conditioning group to have improved because of expectations and not conditioning. Conditioning responses tend to be more responsive for objective data, whereas expectations there's a little bit more leeway in subjective biases as opposed to actual physiological changes which we find with conditioning all the time. So what conditions are they effective for? I think initially research started to look into what type of person would be more likely to experience a placebo effect, with the idea that those who were anxious, suggestible, those who are dependent or dominated by others, those with high levels of agreeableness and optimism were expected to be termed as responders. But I don't think there's much evidence to support it. It's not that I've read anyway. What is shown is that children are very responsive to placebos, and it may be due to some of those traits which I just mentioned. Personally, I think there may be a bigger emphasis on what's within a person and actually spoken about, but what tends to be written is that the best way to determine whether someone's going to experience a placebo effect is generally not related to personality, it's actually related to the illness or condition itself. Things that respond really well are panic disorders, mild to moderate depression, generalised anxiety disorder, and when given a placebo they tend to do just as well, if not slightly below active treatments. Conditions such as dementia, schizophrenia, and OCD tend to be less responsive to placebos, which kind of argues against the thought that 1 in 3 people are responders. It kind of depends on the condition being treated. So any study or meta-analysis which looks at placebo responsiveness, it might include 200 studies, but if it includes 200 studies covering 4 different conditions, then you can't really generalise the level of responsiveness across all conditions. You'd be better looking at 50 studies for each condition and saying in separate papers or reports, yes, we looked at placebo response on pain or Parkinson's and found that this particular condition is X responsive to treatment, rather than a third of people are responsive, which seems to be written everywhere. So I think if I give 30 people placebos who are cancer patients, are 10 of them going to get better? Of course not. But if I give 30 placebos to people who have pain and tell them they're painkillers, there's a much greater chance that 10 people are going to benefit from them. And this is important for something like depression because there's different severities. Saying X amount of people respond to depression is too broad because there's different levels, different stages. With low to moderate depression, you're likely to get between 50 to 70% improvement, but with severe depression, it's only around 20%. And because mild depression is so responsive, drug companies hate it. And they see the placebo effect as a nuisance because they have to compare their new drugs against something which is actually already quite effective. So it decreases the chances of bringing these new pills out onto the market. The conditions I said that responds well were general anxiety disorder, mild depression, panic disorders, and it's obvious that they're very psychological based with subjective elements. By that I mean particularly with anxiety and panic disorders, it's down to a person's interpretation of the situation as the problem, not necessarily the situation itself, which is why they respond so well, as opposed to things like dementia, schizophrenia, clinical depression, which normally are a result of a lack of chemical or damage to an area of the brain. So they're a lot more objective rather than subjective interpretations, which if the person allows, can be changed, and often they need a reason or an intervention to allow them to just slightly change how they view things, which is partly why I think placebos work. And some suggest that this is why psychotherapy works, because the tablet or the person kind of gives them permission to slightly question the condition and allows for that movement to happen, along with other things such as the psychosocial environment. If I have anxiety disorder, I just stay in my room, it's likely to get worse. If I'm with a therapist or a psychiatrist, their care in nature, their reassurance, their encouragement is enough to help reduce my anxiety, regardless of any underlying theory that shapes that form of therapy. Something else that responds well is pain. It's one of the most widely researched areas, and it's also very subjective as well. It can be reduced through both expectations and conditioning. The starting point is likely to be due to a paper by Beecher, which was written in 1955, just before then he was an anesthesiologist on a battlefield in the Second World War. So obviously he came into contact with acute pain to life-threatening wounds. Painkillers started to run low, so he treated some of those people with a placebo, telling them that it was an actual painkiller, probably morphine. And to his surprise, some of the soldiers in the war experienced pain relief. In 1955, he published a paper reviewing controlled trials. And he's the person that said or found that 1 in 3 people are responders. But only a few conditions were actually looked at in his paper. But when it comes to pain, what we do know is that suggestions that provide certain expectations have a much stronger effect on someone than uncertain expectations. So imagine you have 3 groups. One group is a control group and given nothing. The second group is given a placebo and told that they have 50-50 chance of either having a placebo or a painkiller. And a third group is given a placebo and told that they are getting a painkiller. Now the third group's expectations of you are getting a painkiller always, or is more likely to, produce a greater analgesic effect than a group that's told you may get a painkiller, you may not. So verbal suggestions create these expectations, which is the key to producing a response. And this is backed up by studies which use questionnaires to assess people's expectations. There's a strong correlation between those who expect to experience pain and those who actually do. This suggested level of strength also influences the amount of pain felt. If you give a strong, medium and mild cream to someone, people experience pain relief in that order. So when they're expecting to get the strongest cream, they get the strongest pain relief. When they're expecting to get the mildest cream, they get the least pain relief. Yet the creams are exactly the same, which shows the outcome is based on the expectations or the information that we give them based on it. So when we have these expectations of pain relief, it activates endogenous mechanisms which cause the release of endogenous opioids. Now opioids are analgesics or painkillers and include drugs such as heroin, morphine. Endogenous opioids are our body's natural painkiller. So the interesting thing is that the expectations of pain relief causes the body to release its own natural painkiller. And if naloxone is given to someone, naloxone is an opioid antagonist which blocks the opioid receptors. Then there's no placebo analgesia, shows that opioids are involved, which makes sense if it's in relation to pain. Now there are different times in which someone can feel pain. Pain is both psychologically constructed and felt, which includes a cognitive evaluation of what's happening, but then also it has sensory components. So the cognitive evaluation is the awareness of what's happening, and that, yes, this should be hurting. And obviously the sensory component is the nerves and neurotransmitters feeding information from the point of the body up to the brain. Now placebos are less effective when the pain experienced is dominated by the pain sensation itself. So being caused pain at that moment in time, as opposed to the sensory side after, which is more responsive. Put simply, in a dramatic fall, you'll have less of a placebo effect if someone's cutting through your arm than if it's already been cut off. So being aware that you're having pain caused is harder to control with placebos than, for example, post-operative pain. An easier example to understand is if you're being burnt, you'll get pain relief of 1%. Once you've been burnt and you're dealing with the sensations afterwards, you might get pain relief of 20%. Okay? Other conditions such as Parkinson's disease have been shown to be improved with placebos. Now Parkinson's is typically a motor or a movement disorder, but it can have sensory and cognitive effects as well, affecting someone's mood and sleep. With movement, the three main effects are tremors, which occur at rest and is normally in the hands and arms, rigidity, which is in the muscles, and bradykinesia, which is the slowing down of movement as things start to get a little bit more difficult. Now Parkinson's affects dopamine neurons, and dopamine helps with the function of the basal ganglia, and the basal ganglia is responsible for coordination and movement. So when dopamine is low, it causes problems with movement, which is why people with Parkinson's disease suffer from those three conditions. Now it's often treated with L-dopa or levodopa, which is transformed into dopamine in the body. A placebo used instead of this actually causes dopamine to be released in the striatum, which has been found to raise levels almost to the same as someone who isn't suffering from Parkinson's disease. When real treatments are compared against placebos, the size of the improvement isn't necessarily different from one another, but they are both significant and showing significant improvements compared to baseline or no treatment. So a typical study would involve a placebo being administered with the verbal suggestion of motor improvement. Other studies have used deep brain stimulation with both positive and negative suggestions, and regardless of the brain stimulation, the tremors and rigidity all follow the suggested and expected direction. Likewise, when you're actually receiving treatment and told that you aren't, people don't improve when not actually receiving treatment. So Parkinson's is clearly affected by someone's expectations. Now I'll just go back to depression. Alongside pain and Parkinson's, depression in mild to moderate is also quite responsive. It's a mood disorder characterised by lower moods, lack of interest in what's going on, and reduced ability to actually experience pleasure. Unlike with Parkinson's disease, it tends to be linked with reduced serotonin in the person, which is why antidepressants tend to have a dose of serotonin in them. But they actually have a very high placebo component. There was a measurement actually conducted which included around 2,000 people, and it concluded that around 75% of the improvement is actually due to the placebo effect. So only 25% is due to the actual antidepressant itself. Obviously, like I mentioned before, spontaneous remission, regression to the mean, which can probably account for around a quarter or 25% of the effect. But that still leaves half the improvement being down to the psychological component rather than the actual medication. Now, interestingly, with depression as well, the size and probability of improvement is related to the expected benefit. Those who believe that, yes, these tablets are going to help me, experience a much stronger antidepressant effect than people who think, okay, yeah, I'll take them, but they probably won't work. Now, the problem with using placebos in place of antidepressants is that you actually need a course of tablets to experience effects. Unlike with pain, if you're depressed, you're not just going to get over it after one tablet or a day's worth of tablets. You need a 2-week course of tablets to experience actual changes, because it's a deepened mood and state as opposed to a subjective feeling. Now, you might feel a bit happier after a day or two, but to change something that's at a deeper level, you need more time. And then this raises more ethical questions as to whether you can or should withhold effective treatment from someone. Now, it does get a little bit more complicated with addiction. I've been saying how placebos work through conditioning and expectations. If you're trying to get someone off a particular medication or replacing it with a placebo, it is harder because as well as conditioning and expectation effects, there's also the actual drug effects that is harder to mimic naturally in the human body. Although conditioning produces drug-like responses such as with the use of opioids, if you're replacing heroin, the body's natural opioid system is unlikely to be able to match the effect that you would feel from heroin. So you would still have that deficit in improvement. So giving someone a placebo will satisfy the psychological component and expectation pathways, much like it would a conditioning side, if the placebo is the same colour, size, taste, and so on. But the physiological change won't match up with addictive drugs. So with stronger drugs are not as effective with weaker drugs because your body can't reach the levels that it's used to. Now, expectations do play a large role in that. Those who expect to receive a drug tend to report a higher high than those who don't expect it. So again, with alcohol, I think there's a study by Richard Wiseman, or at least he spoke about it in one of his books, that there was a group of students in a pub who were given blue and pink badges, 2 different groups, and there was a free bar where students could go and drink whatever they wanted, so long as they agreed to perform certain tests for the study. So the tests were a reaction time test, I think, using the brew drop, a memory test, and then just walking in a straight line. So it's like when honor students got stronger and their performances in these tests started to decline. But, you know what I'm going to say? Only one of the groups was getting actual alcohol, and the other group was getting the alcohol placebos, or alcohol-free drinks, but they were both negatively affected. And then when they were told that they hadn't had real alcohol, instantly they sobered up and they were all fine. And this is true. You can give someone an alcohol-free drink and tell them it's actually beer. You'll notice that their behaviour will slightly change. They might get a little bit louder, a little bit more confident, as if they were actually having real alcohol. And this is heightened if you're in a pub, as opposed to at home, because it's related to conditioning. Because that's a place where real alcohol's been consumed before, you've had a glass in your hand before, you've got a little bit drunk there before, so your body's subconsciously expecting this drunk state to reappear, because that's what normally happens when you're in that place with that drink. But obviously the effects aren't going to be as dramatic or severe. It'll sort of plateau before you get to the kissing 50-year-olds and demanding a kebab stage. But then nothing's guaranteed as well. It's not as simple as me giving you a paracetamol, telling you it's a sleeping tablet, and then for me to just stand and watch you fall asleep, because that's what you're expecting to do. But there are things you can do to kind of help encourage and facilitate this response. Okay. So we know what they are, how they work, and what they can be used for. I kind of then think, if we know we can create these responses, can we use them to our advantage? I'll just say actually before I move on to this bit that nothing's guaranteed. It's not as simple as saying, have a paracetamol, this is a sleeping tablet, and watch a minute a day. It's a bit more complicated. It might just be me, but I try not to just accept something at face value. So if a study says, administering 2 red placebo capsules 1 hour before pulling someone's tooth out significantly decreases pain by 70%. Now, although that's the mean, it's not quite as simple as saying that, because that doesn't really give us much information. Now, analgesia, if you don't know, is the absence of pain. So does that mean everybody's pain is decreased 70%? Does it mean everyone has a numbness or lack of feeling in their mouth or gums? Probably not. If you take a group of 10 people, their responses will not all be A. Their responses will not all be B. Using pain as an example, people's pain relief will appear along the continuum, from no change in pain to a slight improvement, all the way up to a complete loss of sensation and analgesia. Exactly the same with Parkinson's. Exactly the same with depression. It will appear somewhere along this scale and continuum. So we see this 70% improvement, and we give 2 red tablets to the next patient in, instead of real medication or an injection. The trouble is, this person actually only has a decrease of pain of 5%. So he's not going to be very happy when you start yanking on his tooth. But the reason the study reports 70% is because some people were very responsive and they've had complete analgesia. So when averaged out, it kind of looks like a big improvement. Yeah, for some people, there wasn't any improvement at all. Right, so the majority of effects be due to expectations which arise from things which are in a psychosocial context or environment. Now, it can be manipulated and used to just slightly shift that response a little bit further up, just to get a little bit more out of it, kind of enhance the placebo effect. You can just change a few things. For example, a simple one is colour of the pill. If we look at blue versus red, blues are better for conditions which need calming, so phobias or anxiety, whereas reds are better for conditions which need a form of stimulant. And I think it's because of other associations we have with these colours. Blues associated with the sky, the sea, which are normally quite calming, which is why blues and greens are quite good for being hypnotic and sedatives. Then there's reds, which is associated with fire, the devil, so it's a lot more fierce, which is why, or might be why, they're better for some conditions. The amount of tablets that you give to someone as well can strengthen it. Giving someone 1 a day or 4 a day, obviously 4 a day increases your expectations. It makes you think, because you're taking a lot more tablets, it's likely to have a much stronger effect than merely just taking 1 or 2 a day. So that increases the likelihood of them working. The type or size of the pill. Capsules work better than tablets because they're normally bigger. Injections work better than both of those because, again, injections are invasive, so it heightens the severity and expectations. I haven't come across anything comparing placebo surgery with injections, but I'm pretty sure that would follow the same trend of being the most effective. The packaging as well, the prices, that they all influence the outcome. A 10p paracetamol is less effective than a £12 tablet, which is spelt like you've dropped a bag of Scrabble tiles. I mentioned about open and hidden administrations. They work in the same way. Knowing you're receiving the substance as opposed to having it through a drip without knowing dramatically increases the strength of the effect. The person giving it to you as well plays a huge role. If I give you something and said, take this and it'll make you better, it's unlikely to have anywhere near the effect than a doctor giving it to you. The doctor's likely to have much more influence on your illness than what me or someone else would. The language used as well, in the basic sense, if someone says take this twice a day, your rash will clear up, no problem, you're back to normal, versus okay, I want you to try this and hopefully it'll help. Clearly the first one increases your expectations more. The doctor's approach and attitude helps. Similar to what I said about psychotherapy, if you have a doctor or an expert in front of you who's checking you over, the attention he gives you, the understanding he has, his confidence in that you're going to get better, him running tests and diagnosing you, all help put you at ease, because it makes you think, okay, so we now know what's wrong, and we can now control for it. I'm going to be okay. It reduces the worry and concern that comes with illness. It increases the expectations of getting better before you've even been given any medication. It can even run tests which are completely unrelated to what you're there for, maybe your blood pressure, because he knows your blood pressure is going to be okay, and you would like to hear that. Okay. So when you go to a doctor, you don't just get medicine to help you, you get all different pieces of information. You get things from the environment which reassure you're going to be okay. You get a medical assessment, a chance to discuss your symptoms, the diagnosis, treatment, new knowledge, attention, confidence that you're going to be okay. All which give you hope, confidence, reduce anxiety, and produce expectations about getting better. There's the white coat, the heart rate monitor, the skeleton, the smell, certificates on the wall. The prescription notepad. You know, we don't need prescription notepads anymore, everything's on computer. But that bit of paper is a powerful piece of paper. Walking out with that piece of paper says, I have a problem, it's been diagnosed, and this is what I need to get better. As opposed to walking out of a doctor's room with nothing. People go to a doctor because they want an answer, and they're leaving with an answer in their hand. So again, all of this might be why things such as depression, anxiety, pain, insomnia, blood pressure are so responsive to placebos, because they're all influenced and heightened by anxiety, worry, distress, which a placebo and treatment situation can all help to reduce. The trouble I think nowadays is that doctors' time and resources are stretched, so they don't really have the time to conduct a thorough assessment or to provide you with enough reassurance that they potentially could, which sadly may reduce the psychosocial context playing as big of a part as it potentially could. It's often shown in psychotherapy that one of the most reliable signs about the outcome of therapy is the therapist or doctor-patient relationship. Those who adopt a warm, friendly, reassuring manner have much more effective consultations than those who are very formal and don't offer much reassurance. So the treatment situation is unlikely to influence an actual disease or disability, but there's no doubt it has a powerful influence on illness, apprehension, discouragement, pain, and other subjective symptoms which come with being ill. And you might have found it yourself. I have. You know, when you're in a doctor's waiting room, all of a sudden your symptoms aren't really there anymore, or at least they're not as bad as they once were a couple of days ago. In fact, I was talking to a friend of mine a couple of weeks ago about this, and I was just bouncing some ideas off and coming up with some ideas about what's maybe relevant to talk about. And he said, Jordan, what is the point in you reading about all this? Because you can't use it, can you? And it kind of stumped me, and I thought, you're right, I can't really go around injecting people and telling them that their legs are numb and then hoping that they fall over for a laugh. Then when I was driving home, I kind of thought, well, yeah, it can be used, and I think millions of people use it every day. The trouble is, to say something is a placebo effect or placebo response, you need to have given the person a placebo in the first place. So a pill, a tablet, injection. If a placebo hasn't been given, you can't really call it a placebo effect or placebo response. What you can call it is a placebo-like response. And placebo-like response is quite common because we don't actually have to give anything for it. So a response would come from all those psychosocial factors I mentioned that doctors can give. If a child falls over and cuts his knee, for example, then a parent will come to the rescue, wipe the blood away, kiss the knee better, and then say, look, all better, and And this provides evaluation, attention, soothing, reassurance, which we've already seen is beneficial, especially for pain. And I think this has kind of been lost a little bit nowadays with doctors taking a bit more of a detached approach because, you know, there's boxes to tick or a procedure to follow. Everything nowadays is a theory, a model, a questionnaire. And depending on what answers you give, kind of depends on who you're sent to go on to see, which kind of loses that caring nature a little bit. Now they are sympathetic, they are understanding, and they do give you attention and reassurance, but I think what used to be has been interrupted with, you know, these new diagnostic tools and assessments, which is kind of a quick way of diagnosing someone, which actually reduces the personal side of things, I think. It makes it a little bit more fixed. When someone comes in, you do A, B, C. Now, I might be wrong, but it tends to be the kind of thing that's reported nowadays because there's less time, less doctors, and more patients. With that thing, I think there's an urgency as well to diagnose people as well. You could have a couple of people with the same illness, perhaps. If there's a book going around, instead of doing a thorough assessment on the next person, which would benefit them, which was probably done with the first couple of people, there's a tendency to think, okay, before I even look at you, it's likely to be norovirus because the last 5 people have had it. So again, giving them a hug better kind of thing has been removed. Not that you'd want to hug someone with norovirus anyway. But yeah, we can use what we know to enhance or create it, and it's used in everyday things, even if you don't know it, like a child getting hurt or burnt, or, you know, the comfort and reassurance you give can create a placebo-like effect. If you've got stomach pain, I could say, yeah, I had it earlier, but after half an hour it was gone. Now, I won't be lying to you, but you can use a suggestion, create an expectation in someone in that way. I don't know what else I can say really. If you want to use it, it will literally be trying to use those things which I mentioned, which enhance it. Now, there's a few stronger techniques and other things that can be done, which I won't go into, but it's mainly based around creating the highest expectations possible, because the higher the expectations, the higher chance of it working. Okay. Right. So the negatives and nocebo effects. I think one of the negatives is partly why I was a little bit hesitant about talking about them today, is because the more you know about them and how they work, it gives you more information to kind of question any treatment or medication that you yourself might be taking. If we take the antidepressant example, where 25% of the improvement is due to the medication, 25% natural causes and 50% placebo effect. More information about the techniques and ways which they work means that the person can question whether or not this pill actually is going to work or not, which could reduce that potential for the 50% improvement. So all of a sudden, the person's only going to receive between 25 to 50% of potential improvement than what they could have had if they just accepted and not questioned what they were taking. It's a bit like persuasion techniques or language patterns in hypnosis. Once you're aware of them, you become a little bit less susceptible to them. So when it comes to medication, it's probably best not to question them because you're better off receiving a positive placebo effect than no effect at all. Because ultimately it's going to benefit you even if it is not down to actual drug effects. In relation to nocebos, placebo effects aren't always as nice and straightforward as they sound. It's definitely there, it definitely exists, it definitely plays a big part in improvements that you find with medications. And if you can produce these positive effects and experiences, you wouldn't be wrong to question, can it produce negative effects and negative experiences? And yes, it can. And these negatives are termed nocebo effects. Placebo is Latin for I shall please, nocebo is Latin for I shall harm. Now there's a lot of research, a lot more research on placebos and nocebos, because creating a negative experience or effect in someone when you don't really need to isn't exactly ethical. But they're created in a very similar way, through negative expectations. Now the easiest example to understand is when doctors prescribe a course of tablets, they have to tell patients about the potential side effects. And by telling them about those side effects, can actually contribute to these side effects occurring. So if you're given something and told you might experience headaches, you're much more likely to experience headaches than if you wasn't told that. Okay? So if we go back to pain, the placebo effect with pain is analgesia, so we have the absence of pain. The nocebo effect is hyperalgesia, which is an increased sensitivity to pain. And it's something which we come across in everyday life. And it's one of the reasons why you shouldn't diagnose yourself on the internet. You know, you have a headache, you type the word headache into Google, what comes up? Probably the word tumour. And then all of a sudden your headache starts to feel worse and you start to tune into all these additional sensations and feelings which you might have beforehand just ignored. Because pain is quite a subjective thing, it can be increased or decreased by your mood, anxiety, by levels of concentration and attention that you give to it. For example, if you're not aware you've cut your finger or grazed your knee, it's only when someone says, "Are you okay? You're bleeding. Do you want to go and wipe your knee or your elbow off?" And then you see it and all of a sudden it starts to sting. A similar thing with hidden administration of a painkiller, when they're interrupted. Both groups of patients have an operation and are receiving morphine or painkiller through a drip. They both continue to receive it, but if one group is told they're no longer receiving the painkiller, all of a sudden it creates this hyperalgesia because they're expecting to feel pain because they believe the painkiller has been taken away. But actually it hasn't, as are still receiving it. So nocebo expectations can actually override genuine treatment effects if you are, or at least in some studies, affected to feel an increase in pain. It can actually override an actual painkiller. Now the thing with nocebos is that they can be reduced by diazepam, which would suggest that there's an element of anxiety involved, much like, not that placebo is being administered, but you can receive nocebo-like effects in a doctor or dentist's waiting room because you're conditioned to have negative feelings and possibly pain whenever you're in that room or building, as well as having high levels of anxiety when you're there waiting as well. Much like with cancer patients who have chemotherapy, it's common for them to have anticipatory nausea or vomiting before they actually go and have a chemotherapy session. So these nocebo effects can come about just like placebo effects and negative expectations through conditioning, through knowledge and information about whether they are or not receiving treatment still, which obviously links to expectations. And then anxiety and stress just amplify this level of pain felt. There's some people who are more susceptible to nocebos. People who are pessimistic have a bigger nocebo effect than optimists. People who have deactivated or inhibited dopamine and opioid release tend to also have larger nocebo effects, which is probably quite obvious considering dopamine and opioids are linked to positive placebo effects. In fact, I saw a TV program. They were filming inside a doctor's office and they had a patient with him, and I think he was having trouble walking and getting around. It's a fairly old guy, and as you get older you start to lose your physical abilities and strength and so on. And a few months ago I was reading around the area of happiness and subjective well-being and that kind of thing. And as we get older, because we can't think how we used to think, do what we used to do, at speeds and level we used to do them, the endowment and contrast which comes with that tends to result in decreases in someone's subjective well-being, in which they can experience frustration, helplessness and depression. So this doctor had this man in his office and said something like, "I can see that your legs, or whatever it is that was wrong with them, is affecting your ability to get around and carry on daily life. And the way you've been talking to me today, I think there may be a bit of depression. But we're not going to focus on that at the moment. For now, we're just going to focus on getting you up and moving around. Then don't mention depression. Fair enough, treat his legs because that's what's causing the problem, but you shouldn't, especially a doctor, with the authority and suggestibility he can bring out in a person. You know, you can't diagnose something and then not treat someone for it. He's going to even think, okay, maybe I am depressed, maybe I should be feeling bad. And now here comes anxiety about his own mental state. Here comes the nocebo effects, which may actually lead him to start feeling depressed, or even worse if he was already. So if he suggests that there may be a problem, he needs to treat that problem to help put that person at ease. Or you could say something like, I think we can both see that you're in a bit of a lowered mood at the moment, and that's being caused by your reduced ability to get around. So what we're going to do is we're going to focus on getting you up and moving around properly, and then you'll find that your mood will be increased and you'll be a lot happier day to day. So it's creating these positive expectations. It's being enthusiastic about getting better, and future benefit rather than you have depression but we're not going to treat you for it. It just brings along these negative stigmas and beliefs about depression the person didn't need to associate with themselves. It just reminded me of that. You can create both positive and negative effects in someone through suggestion, even without a placebo being given. In that case, they're placebo-like effects or nocebo-like effects, where there's not actually a physical placebo. So staying on placebo-like effects, there's some researchers who have argued that psychotherapy in itself is a placebo-like effect. And it's obviously caused a huge debate, especially because psychotherapy is a profession in itself, which people train years and years for, saying that I think that's a problem, how it's kind of been said and interpreted, because saying it's a placebo or placebo-like effect isn't saying it's ineffective. What it is saying is that's no more effective than a placebo in some conditions. And that's only because placebos are effective. For example, in mild to moderate depression, psychotherapy, antidepressants, and placebos are all pretty much on par with how effective they are. And I'm sure you'll be able to find a meta-analysis which shows how equal these treatments are. So you say, okay, what do these three conditions have in common? I touched on them before. Someone in distress, personal authority or an expert dealing with a situation, positive expectations, reduced anxiety. The behaviour of going to see a therapist in itself is quite powerful. On that regard, I don't know much about therapy and its approaches, but there's apparently a researcher who devoted his entire career to research in psychotherapy and their effectiveness. There's over 100 different approaches. They are all fairly equal, regardless of any theoretical underpinning of each type of therapy, probably because they all contain the factors which I just mentioned. So that's the question of what size of the improvement in psychotherapy is actually down to the psychotherapy itself. Now, that's not something I can answer. But even if the effect is minimal, I think it still has its place because of everything else that comes with it. The problem is, though, we might have people training 5 years of their lives in techniques which have little effect. But then you need them to be there to be able to produce that minimum a placebo-like effect. And if it is that, or at least part of that, then that's good because the therapist tends to have more of an in-depth conversation than what a doctor can, which can help reduce these anxieties, get things off your chest, which I think people experience all the time anyway. If something's bothering you, you talk to a friend, you generally tend to feel better. And I'm not saying that's effective for things like post-traumatic stress, or someone who has agoraphobia, but I do find it interesting to what size of therapist effects, in inverted commas, is actually down to the work of the person themselves as opposed to the therapist that's cured me. I think to some extent, particularly for anxiety-based conditions, once we allow ourselves to change the story in our heads, we tend to be able to cope okay. More deep-rooted clinical conditions obviously do need professional help and medication. I find it interesting to what extent we actually do this stuff ourselves, and how we attribute what is thought to be the cause of change, rightly or wrongly. Because we're in a world nowadays where if we have a small problem, we pass that responsibility on to somebody else. If you look at the use of personal trainers, you have someone who's overweight and does an exercise and decides it's time to change, so they get a personal trainer and say, make me thin. And they have training sessions twice a week for a series of months and then lose weight. Brilliant, well done. And then a personal trainer takes credit because their client's lost 2 stone. But if that person cycled on an exercise bike for the same 2 hours a week, they'd have still lost that 2 stone and still have £200 left in their pocket. So in that situation, is the personal trainer effective? Maybe not, especially against the control of just exercise yourself. So the weight loss is assigned to this hero trainer, but then the person wasn't even doing anything to do stuff, so of course you're going to improve. Now from an exercise psychology perspective, they are good because they help with commitment, motivation, but again, you can take responsibility for that yourself. Now don't get me wrong, this is mainly for people who are looking for that quick fix, and people who don't do anything prior to getting a personal trainer. If they put the effort in themselves, they'll find results. But we're in a world where we throw ourselves at job titles because that defines a person of being a professional in that field, and that person can cure this problem that I have. But if it works for you, it works for you. And going back to psychotherapy, it is more effective for some conditions than a placebo, like OCD, so brilliant, use it. I just think it's important to question whether the mechanisms you think are at work are actually at work, or could doing something else produce very similar results. Okay. Now, if you wanted to use placebos in a study, how you would use them would depend on what it is you're looking for. If you're testing new medication, the best way is a randomized controlled trial, or RCT. Double blind as well, if that's possible, but at minimal single blind. It's not uncommon to have two groups, so the experimental or medication group, and then the placebo group as the control group. Personally, I think 3 groups is best, so medication, placebo, and no treatment, because that will help you distinguish between the actual medicinal effects, the size of the placebo effect, and the likelihood of someone getting better from that condition without taking anything. Obviously, depending on the condition, that's not always possible because of ethics and denying people treatment. You can get away with 2 groups because the placebo group does increase potential remission, but being interested in the placebo effect, I like to know how much is actually a placebo effect. But even using a no treatment group, control groups, not always as simple as saying remove that from the placebo group's improvement, because of the characteristics and severity of the illness in the people in each group can influence how big that change is. If you look at the placebo effect itself, then just 2 groups is fine, because you'll have a no treatment group, which is the control, and then the placebo group, which will obviously tell you the size of the placebo effect, once you subtract the improvement of the control group. So if you're testing the effect of caffeine on the time to perform a 10k cycle, the basic way to do it is 2 groups, both perform with nothing, then one group performs with caffeine, the other performs with placebo. And then the size of improvement is compared between the 2 groups. And that will be a basic design. It's not brilliant because you have one group perform with and one without. And you may have people who are highly responsive to placebos in the placebo group, so they get a very high placebo response and improvement, whereas in the caffeine group, you get people who aren't very responsive, but they do have a slight improvement due to the caffeine. But because the placebo group is so responsive, it sort of overshadows the effects that caffeine has. And it's concluded then that caffeine has no effect, whereas it did for that particular group because there wasn't much of a placebo effect in there. But because the group is such a large placebo effect, it minimises the improvement of the experimental group. So you can add a crossover element design into the study, which basically means both groups perform both trials, or you have everyone perform 3 trials. One time they'll perform with nothing, which you consider control, and then 2 more times with placebo and caffeine. So you can compare their own scores between trials as opposed to 2 separate groups. So everyone does every trial. That makes more sense to me because it eliminates all the interpersonal factors which can influence results, which is surely better than having 2 separate groups. I think the problem with crossover designs with pharmaceuticals is carryover effects. You may have the actual medication first, then when you come back for the second trial, you're actually better, or you are still experiencing some benefit from the medication. The second would be kind of knowing which group you're in or what you've had, and that's normally because of the side effects that come with what you've taken. So you may have trouble sleeping, so then you kind of know that you've had the actual medicine. So when you come back for the second trial, you know you're going to get a placebo, so you just don't try as hard. Or you expect no benefit, so you get no benefit. You can account for this by using active placebos, but I won't bore you with that. So RCT is crossover designs, having double blind is very important. So the experimenters themselves don't know who's receiving it, because obviously the psychosocial context plays a part. If I know I'm giving you caffeine, I might be a little bit more positive towards you with my attitude or language, which might actually influence your expectations. So double blind helps keep each trial consistent. What's said is the same, what's done, the procedure is all the same, because the only person that knows the order is someone who's not even in the room. Specifically looking at the placebo effect, then it will be the case of a no treatment control group and a placebo group, with the placebo being whatever it is you want to look into. And this could be changing the colour of tablets, different number of tablets, method of administration, 100 different arms, in which they're all given active medication, but then on Tuesday group 1's replaced with placebo, Wednesday group 2's replaced with placebo, Thursday group 3 and so on. And this can be used to see how many days it takes to create conditioning effects. You can assess expectations by giving placebos to 4 different groups and telling them that they're all different strengths and stimulants, or depressants, and see how they respond. It can literally just grow and grow by manipulating expectations, quantity, timing. You can create doubts in some people and assurance in others. All of those conditions can be doubled with 1 hour being administered in a hospital, the other being self-administered at home. You can literally just create thousands of groups. The problem is getting thousands of people to take part and not getting confused with it all. But all that's quite unnecessary anyway. I think the main things that I think are relevant are expectations through verbal suggestion, open and hidden administration, and interrupted course of treatment, because these are things which can be applied to actually help people. The colours of doses are sort of conclusive already, but if we can get people to continue to experience drug effects after treatment has been interrupted without them knowing, then that's brilliant, because it saves people from taking actual medications which are expensive and also likely to produce negative side effects. Yeah, simply if you're testing a placebo effect, then you can do it with 2 groups, no treatment and placebo. If you want to determine the size of the placebo effect in a medical trial, then you need the 3 groups for that. With that, actually, I just remembered, if you want to see the size of the effect that expectations have, then you can do a balanced placebo design, in which there are 4 groups. So the whole group is split into 2, and that will be your placebo and medicine groups. They will then both be split into tolerance placebo and tolerance and active agent. So that will cover all 4 possibilities. Placebo treatment, expecting placebo. Placebo treatment, expecting medicine. Medicine treatment, expecting placebo. And medicine treatment, expecting medicine. The important group here to look at is the medicine treatment, but expecting placebo, because that will show you the effect of the actual medicine without the expectations of placebo effects in there. I think it's good to include objective measurements as well. So physiological assessments, or things which we can't consciously control, as opposed to subjective measures where people fill out questionnaires. Because you never really know what your person's experiencing. If you put yourself back in the classroom situation, if the teachers explained something and you didn't understand it, they'll explain it again. Whether or not you understand it the second time, they normally say, yeah, I understand it now. And that's why I'm often sceptical of self-report measures in placebo studies. Are they saying they've got less pain or don't feel as depressed because they generally are feeling that way? Or are they saying it because you've invested a lot of time and effort into them? So because you know they want you to be better or want you to have improved, you just kind of say that you have. Right. Ethics. Ethics is kind of a big issue when it comes to this kind of thing. Studies, you have an element of deception. So you're telling someone that they're receiving something, but they aren't. Or in other words, they're lying to them. But second of all, because people go into control groups are being withheld from receiving actual medication which is known to work. So there's deceiving people, but then there's also denying people actual treatment. If you have a group of depressed people who clearly need help, how can you put some of those people in a control group who receive nothing? Likewise, how can you put some of those people in a placebo group who also technically receive nothing? Now this is overcome by telling people that they're taking part in a research project, obviously getting their written consent, and they're informed that they have a 50-50 chance of receiving a placebo or an active treatment. Likewise, if doctors will prescribe a placebo, they can't say, okay, these are antidepressants and they'll make you feel better. But what they can say is that I'm going to prescribe you some tablets, and there's some research out there that suggests that it will help, which is quite sneaky, but there is some research which doctors and physicians have admitted that they've administered placebos for some conditions. And it's a perfect solution for hypochondriacs because they need something to please them for that moment in time. And what better to please someone than a placebo? Which again, some argue is unethical, but if it's clear that that person isn't actually suffering from an underlying condition, then prescribing them with something just to satisfy them puts them at risk of unnecessary side effects, whereas a placebo will satisfy them just the same without the side effects. Likewise, they could potentially be given a placebo for unspecific conditions or unspecific symptoms. If you don't know what's actually wrong with someone, or to avoid conflict if the patient is demanding medication when they don't actually need it. But yeah, there's that ethical line. I think it's fairly uncommon for doctors to prescribe placebos, particularly if there's medication that's been proven to work. It can only really be considered when there's no clear effective treatment, or when placebos are just as effective as natural treatment, and you need to eliminate side effects for whatever reason. Obviously, they shouldn't even be considered with severe illness, or when people will suffer from having delayed treatments. There are surveys, however, in which people report that placebos are generally accepted around 60-70% of people. For some conditions, people will accept placebo as a first-line treatment, especially parents regarding their children, because it means that they don't have to give their children medication. And it's even seen in people that enroll in research trials. They know they have a 50-50 chance of getting a placebo, yet they're still willing to take part. Yet if they refuse to take part or don't agree to take part, they'll be given genuine treatment, but obviously people are still willing to enroll and take that chance. I think the biggest problem comes with placebo surgery because it's an invasive surgery and often causes the person to be left with scar tissue, blood loss during the procedure. But if placebo surgery isn't performed, how do we know that actual surgery is effective? Obviously, physical repairs are effective, but using arthritis in the knee as an example, in assessments 1 and 2 years after surgery, it's often the same level of self-reported pain in those who have had genuine surgery and those who have had placebo surgery. There's also a debate in using placebo effects in sport. I think BD is the main researcher to write about this in sport. And the question comes from weightlifters and athletes have been known to use painkillers and morphine to get them through training, to really push those barriers. But obviously morphine's banned in competitions. Now the question is, can you condition placebo analgesia by using morphine so that when you go into competition you receive the same effect of morphine from a saline solution? Now can you do it? Yes. Is it allowed to be done? Will anyone know it's being done? I'll let you decide on that one. So you'll be glad to know this is the last slide. I just want to finish on coming off the back of ethics by just giving my own thoughts on whether or not they should actually be used. You know, if they're considered being ethical because of deception and denying treatment, then should they just be limited to research trials in which they're used as a control? I would say no, and the reason is, the thing is when people are given placebos, the risk comes from the illness that they have, not the actual placebo itself, other than obviously placebo surgery, which does put someone at necessary risk. But it's needed to see if these millions of pounds spent surgery is worthwhile. The problem I see is that if the improvements in surgery are placebo effects, you still need to create that effect for someone to benefit. Okay, so if I use an example of a bench press, you can bench 100 kilograms. With creatine and with a placebo, you do 105 kilograms. Okay, so creatine is seen as ineffective because it's on par with a placebo, so it's not taken. But now you're missing out on this effect, which can get you an extra 5 kilograms because you're not taking anything. So saying something is ineffective because it works for a placebo effect, you know, is that line of ethics and what's morally acceptable on one side to trying to get the best result and response from someone, even if it is based on false assumptions. If we look at medications, say antidepressants in research trials, if someone in a placebo group improves from taking a placebo, would it then be unethical to continue them on that placebo after the research is finished? I would keep them on placebos, but then it's not my decision. You know, doctors have their jobs on the line, probably have to give actual medication, which is not needed and is going to produce side effects. So no, I don't think giving placebos is a bad thing, but I look at it from a psychological perspective. People from other backgrounds, such as the physical science, will probably argue against it. But obviously I think they are only applicable to some conditions, and there's lots of variables which need to be taken into account, such as the condition itself, how long the symptoms have been present, the severity, the person's mental health background, the likelihood of someone getting worse, the availability of the person to come in for regular checkups, whether the conditions affecting their work and personal life. I think you'll struggle to get a criteria which includes everything and then leads down to a yes or no answer. So I hope that was at least slightly interesting for some of you. Apologies for it going on for so long. The main message I want to get across from this is I think we all have the ability to think different, feel different, and more importantly, behave different once we give ourselves permission. The trouble is we don't give ourselves permission. We get trapped in our daily patterns of thinking, feeling, behaving, which actually gets us nowhere. And it's so that it takes something external to happen for to be put upon us, such as an illness or death in the family, for us to actually make changes to our lives. When really it's clear we have these abilities within ourselves to make these changes once we take that little sugar pill. Thank you.